Good morning, good afternoon. Welcome to this new webinar, Strategies to Prevent, Detect, and Treat Neonatal Sepsis vis-a-vis antimicrobial resistance. It is my privilege to have your presence. Over 1,600 people connected from all over the Americas and from other regions as well. It is very rewarding, and it is a testament of how relevant the topic that we are discussing today is. Before getting started with the seminar, we remind you of the general aspects. You can select the language of choice, that is interpretation, by clicking on the interpretation button.
For your preference, clicking on the icon identified with the globe to select your language of preference. Pueden utilizar el chat para comunicar cualquier problema técnico y
you can use the chat to communicate any technical issues. And we welcome questions, and this is why we invite you to use the Q&A icon in order to share questions. This seminar is coordinated in a joint manner by two PAHO departments. And for that reason, I'd like to show you or introduce you to the consultant of the program, special program of antimicrobial resistance for PAHO, Monica Chu. Welcome, Monica, to this webinar. And with this, we will formally get started with the seminar. And I'd like to invite Dr. Susan Sarusha, the head of Health of Women and Children Health of PAHO, who will give us the welcoming remarks. Thank you, Pablo. Welcome you all on behalf of the Pan American Health Organization. We extend you a warm welcoming. As Pablo said, this seminar is important in and of itself. We have 1,600 people or over 1,600 people to discuss this issue that has to do with two special things. Antimicrobial resistance, such an important topic for us this day and age. This under the Department of Infection preventions, and also under the healthcare service system, the course of life, where care is for the lifetime of a person, care centered around the person. This is how I'd like to start, by thanking these two departments. And in this department that is led by Pilar and Monica, this is the third webinar of this series. It discusses sepsis and infections. The first one was connected to all the strategies that we need to carry out on a daily basis. This is hand washing strategies. It's an international seminar that we conduct every year, followed by maternal sepsis, one of the main causes of maternal mortality in the region. And today we are discussing this topic with specialists of perinatal health and specialists that are related to antimicrobial resistance. The purpose now is for us to update, to discuss knowledge. This comes from the field of epidemiology, and it also involves risk factors. We need to improve surveillance. We need to improve infection controls, the safe management and use of medications or drugs, something being so important in this subject matter, and the rational use of antimicrobials. It is an opportunity for us to discuss very specific strategies, because neonatal sepsis is at the crossroads of two of the most urgent priorities: the survival of the newborn and antimicrobial resistance. And we have a commitment in the region, one that by late 2030, we will manage to reduce neonatal mortality to 2 or less every 1,000 live births in all countries. And of course, neonatal sepsis in almost all countries is the third largest cause of death. The role of infections being so important in the proportion of neonatal deaths are avoidable. So with very specific down-to-earth interventions, these things should actually not happen. Based on this logic, an adequate infection control during the prenatal period, hand hygiene, safe practice for preparation and administration will help us avoid the connection between two vulnerabilities, the newborns that stay for longer admitted in hospitals. These are the premature babies who have health problems, and these premature babies are the ones that are more exposed to intra-hospital infections or hospital-acquired infections and to pathogens that are very resistant in the intensive care units. From the Pan American Health Organization, we offer technical cooperation in maternal health, perinatal and neonatal health, and in trying to reduce microbial resistance or antimicrobial resistance. There are a number of tools that are underway that can always be used. I wanted to focus on one that we have that is actually very special, and it has to do with healthcare teams. This application that is targeted to healthcare teams, specialists, nurses, doctors, and family members around the baby. And at the same time, I'd like to focus your attention to the perinatal information system. In this system, they have the possibility to get to know morbid mortality indicators and sepsis, and to, in real time, improve knowledge, have the data, improve and improve the situation, improve survival, and improve care. PAHO, as you know, and the two departments have an important number of frameworks, regulatory recommendations, and also from the healthcare, from the neonatal healthcare area, we have this in place. It is very well structured around sepsis, on an effort around sepsis. But before I'm done with my role, please grab your mobile phones. Please download through this QR code this application. I believe that we all have to think about the fact that sepsis is framed within a life course approach. An infection in the newborn, in the first few hours, in the first days of existence, should get understood not in an isolated perspective. It is always related to care that the mother had, preconceptionally speaking, perinatally, and during delivery. And of course, this will impact the lifetime of this person. So it is important to have the person-centered view so that the infectious control that we saw in the previous meeting, maternal infectious control and perinatal infection control, will be an important ally to secure the survival of the newborns and so that we achieve the Millennium Development Goal 3. I hope that you enjoyed this webinar that was very carefully prepared. I'd like to thank Pilar's and Monica's leadership, and from our team, the leadership of Pablo Duran, who is the regional advisor of neonatal and children health. We have a great team behind the entire organization. Brenda, Lee, interpreters, translators, people that are behind the streaming session here. But I'd like to thank you because let me tell you that each one of the people that are in this webinar, each one of the persons in this webinar, once you receive the summary after the webinar and the link to the webinar video, well, this will be under our YouTube TV channel. And please share these resources. Many times countries ask for things that are already available, and this information is very relevant. I welcome you kindly. Thank you for having worked behind the scenes for the success of this meeting, and I will now give the floor to Pablo. Thank you all.
Thank you, Doctora Cerrulla. We'll give the floor to Pablo, as mentioned by Dr. Cerrulla. He's the regional advisor in perinatal health for the PAHO. He's going to present the state of the situation of neonatal sepsis in Latin America and the Caribbean. Pablo, you have the floor. Thank you, Monica. Let's upload the presentation and let's set up the show mode. Okay, now let's frame the issue of neonatal sepsis in the Americas. We are all connected because we are aware of the relevance of neonatal sepsis. This is one of the leading preventable causes of neonatal death. These are very important issues. On the one hand, the continuity of the sepsis burden and also the acknowledgement that this is a preventable cause. These two ideas underlie and stress the seriousness and the gravity of this issue. Sepsis is a quality indicator of neonatal life. This is something we are going to stress. Most interventions are well known, but the challenge lies in the implementation of systematic measures because the increased mortality risk of sepsis in the newborns, the impact of lengthening the hospitalization, and also the relationship with serious complications that may lead to long-term disability, and also the burden on healthcare services, the increased costs related to the improper use, the empiric use of antibiotics, which in turn lead to antimicrobial resistance. So, from the perspective of healthcare systems and public health, make this a very significant issue. As we said, there is a persistent burden related to neonatal sepsis. Worldwide, this accounts for 25% of neonatal deaths, affecting over 500,000 newborns every year. In the Americas, the numbers change because there are concurrent causes, but one of 10 neonatal deaths in the Americas in 2024 was related to sepsis. So these data are based on interagency data. So in absolute numbers, we are talking about 12,000 neonatal deaths related to sepsis. So this shows the high burden and also the persistence of the prevalence in the Americas. As you can see on the screen, even though the neonatal mortality rate has decreased from 2020 to 2024, nowadays we are under 8 per 1,000 live births. So on average, we in the Americas, we've reached the 2030 goal. But in blue, you see the behavior of sepsis-related death. As you can see, there's no change in the last 24 years. So this is a persistent situation, a chronic situation. In comparison with other causes of death, in orange, for instance, we see sepsis-related deaths. In green, in blue, meningitis. As you can see, all causes remain unchanged when we disaggregate neonatal mortality. So we see a slight decrease in other mortality causes, but what's important is the plateau of the mortality rate due to sepsis. This is applicable at the regional level, but with differences among countries. Inequalities are another feature of this, as it happens in many other indicators. If you see the contribution of sepsis to mortality rate varies according to the country. In light blue in 2020, in red the data corresponds to 2024. So you can see the wide variability in sepsis-related mortality according to country. The same is applicable when we consider other infections on top of sepsis. So we need to focus locally, not only the analysis, but also the response. Those of us who are here today are aware that the risk of highs have their own features. As we know, prematurity, low birth weight, restricted intrauterine growth, these are increased risks for sepsis. Not only because of this, but also due to organ immaturity, also due to the use of invasive devices such as catheters, and also due to the exposed to microorganisms due to a prolonged stay of the newborn, for instance, in the NICU. So, healthcare measures, of course, are affected by workload, overburden, improper assistance, non-specialized care, low compliance to prevention measures, improper deficits, shortage of supplies. All this affects or has a negative impact on the situation. Well, we know that epidemiological and microbiologic surveillance is essential. We know that proper surveillance will help us monitor sepsis and also identify causing microorganisms to gear the proper measures to specific microorganisms. And this is also helpful to identify outbreaks in an early fashion. Some countries face outbreaks that could have been prevented with proper surveillance. In the Americas, we know there is an under record of cases and outcomes. We know there is and equal access to labs. Many areas, labs are not available 24/7, so we have to strengthen surveillance. This is essential. The best strategy to reduce resistance is prevent infections using antibiotics when indicated in the proper way. So, in healthcare provision, there are many issues that we have to analyze and strengthen in order to provide a proper response. So, to conclude, we know that neonatal sepsis is still a leading cause, a persistent cause of morbidity and mortality, but it is preventable. This also, we know infection prevention and control, surveillance, the stewardship programs, and ongoing improvement on quality. All this must be implemented in an integrated way. And also, another challenge that we face in the region is to translate evidence into safe practices so we can get more positive results for the babies, the families, and our communities. The best strategy to reduce neonatal sepsis goes beyond a clinical practice, beyond the clinical treatment of infections. We need safe health systems, quality systems that are centered around the newborn and their families. Thank you very much. Thank you, Pablo. Now we'll start our dialogue. We have with us four experts that are going to help us analyze neonatal sepsis from four standpoints. First, we'll start with infection control and prevention in neonatal units. Dr. Fernando Espinosa, a doctor neonatologist and founding member of the Latin American Society of Infection Prevention and Control. Fernando, welcome. Next, we'll talk about safe practices in neonatal medication. We have a guest, Ana Quiroga, a registered nurse, who's going to talk about this. Ana runs the specialty of neonatal nursing care in the Austral University in Argentina. Ana, welcome. Next, we'll talk about proper use of antibiotics. We invited Dr. Liliana Vasquez. She's a pediatrician in charge of pediatric and perinatal unit in the Suizo-Argentina Clinic in Buenos Aires. She's a member of the Latin American Society of Infectology. And to talk about safe nutrition, our guest is Dr. Karina Malena, a pediatrician, lecturer in the Ibero-American Neonatology Society, and she works in the Ministry of Health of Dominican Republic. Welcome, Taina. Thank you, Monica. And moving on with our agenda, we'll talk to Fernando. Fernando, let's talk about infection prevention and control in neonatal units. The first question is, would you explain why birth weight, gestational age, underlying conditions, and the exposure to medical devices are risk factors for healthcare-associated infections in neonates. Of course, good morning. I would like to thank Pajo for the invitation to this meeting. Thank you, Pablo, for your question. But before anything, a NICU has high rates of highs in comparison with other areas within a hospital. Another aspect is that technology breakthroughs in neonatology has problems associated. For instance, the increase of highs. So we have three issues here in order to approach risk factors, especially among the babies in the NICU. Most of them are premature. And first, you have to take into account the maturity of the immune system. Then the need of invasive devices and also the severity of the underlying pathology. The main defense barriers in a neonate, the skin and the intestines, are ineffective because critical babies do not get the mother's bacteria that can colonize and improve their defense system. And also, they won't receive the colostrum, so the gut will not be colonized by beneficial bacteria. So, this defense barrier is going to be broken down and is going to ease the way for pathogens. Let's take a preterm. This baby cannot get attachment. We must be quick and aggressive. Most likely, we will have to use resuscitation. Most likely, he will require intubation, mechanical ventilation, maybe arterial lines, peripheral lines is going to be punctured many times to draw blood. So, in a few hours, this newborn will be fully invaded, and one single bacteria in a couple of hours becomes 2,000 million. And also, we have resistant microorganisms. So, critical newborns have many risk factors. And we have to, this is going to increase the risk of infections. So, hand hygiene is critical. Multimodal strategies, early removal of devices, the rational use of antimicrobials, these are going to be the most powerful tools. Thank you, Fernando. Very precise. Next question. Considering these risk factors, the compliance with the 5 moments of hand hygiene in maternity wards and neonatal units can change the course of an outbreak. Well, thank you for this question. First of all, we must take into account that an outbreak is a real emergency and it is essential to know what to do because when we face an outbreak in a neonatal unit, this is a crisis with unforeseen consequences. In Bolivia and Ecuador, an outbreak in a neonatal unit increased mortality, but this also became a scandal that made the headlines and also was a legal problem. So, in case of outbreak, we must study it and we must adopt urgent measures. So, compliance, strict compliance with the 5 moments of hand hygiene is the single most important measure to control an outbreak, and it is the most effective and most economic means to contain this outbreak. So, if we talk about the impact of the 5 moments of hand hygiene during a outbreak, moments 1 and 2 are to avoid new cases. During an outbreak, the bacterial load in the environment is very high. So we must be strict with moment 1 before touching the newborn, and also the moment 2 to implement the aseptic technique. This way, the newborns that are colonized can remain in this state, and we cut the transmission chain. But because we have um, healthy newborns, so hand hygiene before touching the baby or before touching a catheter is going to be an invisible shield that will prevent the onset of new cases. Moments 4 and 5 are a way to avoid new cases because during an outbreak, the environment of a colonized newborn is a reservoir. We have incubators, we have monitors. So, after the contact with the newborn and the environment, these moments are essential to avoid cross contamination so that the staff will not carry the microorganism from one baby to the other. So, if the staff washes their hands immediately after touching the incubator, for instance, the microorganism will not be viable. So, the outbreak is an emergency, and we cannot wait for environmental cultures. And remember that the first line of attack that avoids greater mortality is the strict compliance with the 5 moments. So, this is the most powerful containment measure. Thank you. Let's move on to the third question. Would you please share with us the 3 most effective and economic prevention measures for highs, the most which are most feasible, and when do we have to use a vascular access, sorry. Well, thank you very much. In neonatology, the cost of highs, well, it goes beyond the economic aspect. They have a social aspect. So we must be very efficient. There are 3 measures that must be cost effective. So, in my opinion, first of all, we have to implement programs, surveillance programs. We must train our staff permanently. We also need stewardship programs for antimicrobial use. In this way, we are going to reduce infection rates. But first of all, hand hygiene and the 5 moments with liquid soap, with alcohol, with antiseptic gel. We have to remember that hand hygiene is the number 1 measure, the cheapest, the most effective, and yet the most difficult to comply with. Next, also, we need multimodal strategies. For instance, when there is a central line, we must monitor with a checklist the catheter insertion. We, we must choose the access site, whether it is in the navel or in the periphery. Also, the material to be used must be sterile at all times. Hand hygiene must be surgical. We must comply with aseptic technique. And also we have to clean very thoroughly the puncture sites. And also we have to take into account catheter maintenance. First, check the viability, check whether the line is useful. Sometimes there's no need. Some Sometimes the people say that, well, the baby has no veins, we should leave it just in case. Well, there's no need. Before touching the line, you must wash your hands. The cleaning of the skin and everything that is going to be used must be disinfected with alcohol. So, in summary, to prevent hives, hand hygiene, empowering the healthcare staff that takes care of the newborns, and third, the use of techniques to reduce healthcare associated infections when used properly. Anything else, Pablo? Thank you, Fernando, so much. Crystal clear. Now we'll hand over to Monica. Thank you, Pablo. Now let's talk to Anna about safe practices in neonatal medication. Anna, neonates are one of the most vulnerable populations to medication and feeding error. Which are the three most frequent errors in neonatology? What measures can be implemented to prevent them? Please, could you please discuss good practices related to aseptic preparation of medication, independent checking of doses, correct ID of the patient? Anna? Thank you, Monica. Good morning to all the presents. These topics are really essential for the survival of our patients. Medication in neonatology is also affected by everything that Dr. Spinoza said. This is applicable to our patients in our neonatal units. So, my answer is divided into, on the one hand, the causes and risk factors. First, the calculations you have to make. Sometimes we use medication with adult doses, but doses are weight dependent. If we have a baby that weighs 500 grams, we must make dilutions and we must use mathematical formulas that are complex. And this is prone to errors. Also, we have to stick to the maximum recommended concentrations. All this must be taken into account. Our patients sometimes require very small doses, so the calculations are delicate. Also, system errors. Sometimes we have look-alike, sound-alike medications. Sometimes there are no standardization protocols. Sometimes the protocols are not standardized, and also the work overload for the staff. You must be fully there, 100% on the task. And sometimes when you are overwhelmed by work, this may may make you prone to making mistakes. And also, we must take into account the vulnerability of these patients. Their liver and kidneys are immature. So the clearance and metabolization of these drugs are harder. And as regards medication, we must have dose errors. So we must double check independently the dosing of high risk medication, and we require single standardized concentrations in each unit. Also, we need aseptic techniques. Some institutions have laminar flow hoods. Not all institutions have it. We need a clean area. We need a clean table. We need to clean it every time we are going to prepare medication. And also, we need to avoid interchangeable connectors for parenteral feeding. Sometimes you confuse the administration route, so we must signal properly the enteral and the parenteral routes so you avoid confusion. And also, there are identification errors. Sometimes I will give a medication to one patient and the medication was meant for another patient. So, all patients should wear a bracelet. So, before giving the medication, we can verify that this is the right patient that is going to receive the right medication at the right doses. And we have to also confirm verbally before the administration. And also, we need to check the 5 rights. So, nurses spend most of their time administering medication, and these are the most frequently made errors that we see in this task. Thank you very much, Anna. Your answer had been very thorough. Second question, from the patient's standpoint, which strategies are priority to minimize these errors in the daily practice? Well, I wanted to stress that neonatal medication, the safety of neonatal medication relies less on individual surveillance and more on systems that make it hard to make a mistake. We need a culture of safety, and we need to reduce as much as possible the likelihood of making an error. So we have to encourage a culture of security, and also we must report every error and in an anonymous way. And also, what we are going to do with the report. If I get the report and then I do nothing, if there is no follow up, for instance, if there is no analysis of the situation, nothing is going to change. Errors can be serious or not, but I have to do something with that report. Maybe it's not about punishing the person that made the error. And also remember, if the error is severe, well, the first victim is the patient, and the second victim is the staff that made the error. So this is very stressful for the staff. The guilt, and you know that errors are unwilling. Also, we need standardized protocols and checklists for the administration. We need double checking for preparation and administering. So, however sure you feel that you are doing things right, we must check, and the control must be present to make sure that I am doing things right. Also, supporting technology. There are very few medications that are not infused through an infusion pump. So it's very important to have good pumps. This technology is also going to help us make less mistakes, and also we need a protected environment. The literature shows that when the staff wears a red band, that means they are preparing medication, then everybody knows that she is not to be interrupted.
It should be a place with proper isolation. We should not prepare medications in a place that is not well clean, and where, well, we should be mindful not to disturb the person when preparing medication. The relationship between the nurse and the patient should be adequate, prioritizing on complex patients and to assign them to those more experienced nursing staff. And my contribution goes here. I believe that we have to work with family members. They are partners with us. We know that family members are very careful and very attentive to the needs of patients. Families, parents can help us prevent errors by just asking us, are you sure that this is the medication that you have to administer? This helps us a lot. And nursing staff should always be continuously trained and engage in simulation exercises. Thank you, Anna. Thank you for highlighting on the culture of safety. That's a very hands-on answer. The second question, if you had to recommend 3 highly impactful and low-cost interventions that any neonatal unit should implement to strengthen medications safety, which would you pick and why? Well, on the slide, I was asked to pick on 3, but I chose actually 4. I think that today, this is what we have to discuss about too. We have to understand that neonatal units should be open 24/7 with parents taking care of care. High impact and low cost is double checking, independent and mandatory. It should not be a choice, but it should be mandatory. There should be no medication that is not checked by 2 healthcare professionals separately. I am in charge of calculation, but another person should make an independent calculation to confirm that I am on the right number. They should double check on the right drug, the doses, and the route of administration, especially in high dose or in high risk medication, as a barrier, as an access barrier before administering medication. Second, standardization of concentrations and labeling. A single concentration per drug in the unit with clear labels and color codes to differentiate doses. Medications, there's medications that are high costly in the unit, and what if they are diluted or not? Ideally so, they should be reconstituted at the pharmacy, but not all departments have this availability. So the person in the unit should be preparing the dose, but they have to be very attentive to expiration dates, when it was diluted, at what time it was diluted, so that we don't run the risk of using medications that are not clearly labeled. And the positive identification by the patient with 2ID methods, the purse or the bracelet, sorry, or the patient record. This should be confirmed and double-checked. As you know, these are low-cost strategies, but they still have a high impact in preventing errors and in promoting what we call patients' safety. And without a doubt, the presence of families in the unit, this only adds safety and quality in care. Parents are the ones that notice subtle changes in their children, or they let us know if drugs are administered in an unusual time or in a different manner. We need to work with them next to us, hand in hand with us. And this is one extra additional safety measure, additionally to all the other benefits that are contributed: neurodevelopment, the non-interruption of the bond, and the promotion of attachment behaviors, protection measures, and the development of the brain of that newborn. But in the specific case of medication, parents can help us a lot in keeping everything safe. And they would be the third point of checking. So it's not double checking, but triple checking in not making a mistake or an error in administering the medication. Thank you, Anna, for sharing these strategies that have to do with a high impact and a low cost. I leave now you in the good hands of Paulo. Pablo will help us understand this in more detail. He will walk us through another related topic. Well, we will now focus, Liliana, on the timely use of antibiotic therapy. And the first question to you is, vis-a-vis the detection of infection, presumably associated to healthcare in a neonatal unit, which are the most important challenges that the healthcare team faces in managing a timely diagnosis and an effective management? Good afternoon, you all. Thank you so much for this invitation on behalf of me and SLIPE, the Latin American Association of Pediatric Infectology. I'd like to thank those that are joining us in this webinar. In a very practical manner, I divided this into 3 areas in order to give an answer to this question. The first one, the answer has to be, or the response has to be quick and effective. And here I'd like to talk about the importance of the infusion has in an antimicrobial that should be administered in an early manner and with the necessary priorities that have to be taken into consideration when seriously ill patients are affected. There's lots of studies that talk about survival and the impact that the quick and the rapid infusion of an effective antibiotic has. Every hour of delay in administering an effective antibiotic decreases or results in an about 8% decrease in the first few hours survival. And the rapid antibiotic infusion was also compared to survival in the rapid infusion also of hydrocolloidal solutions, fluids, and ionotropic drugs. And those that had a direct relation with better survival was the quick and the rapid antibiotic infusion. This is a key message, not just for doctors, but for the rest of the healthcare team. On that very extensive list of indications that these patients have, they should prioritize first and foremost to administer or to infuse antibiotics in these patients. And for this to be effective, we have to know what the microbiological reality that our patients in our unit have. What about the most frequently encountered bugs or germs that can affect our patients? And what about antibiotic susceptibility? This will show us the way to go to treat patients adequately or not. And finally, we also have to have use guidelines in place for the rational use of antibiotics as part of our unit that will indicate what the right antibiotic is, what is the right therapeutical doses for these patients that will have the lowest toxicity possible, and how these antibiotic treatments should be reviewed in connection to the time of reevaluation. This will help us determine and go for the right decision to administer antibiotics only to patients that only require it or that really require it, so as to avoid prolonged use of antibiotics. Every day under antibiotics, there's an increased risk of necrotizing enterocolitis, a late sepsis and death. That is, when the antibiotic doesn't do any good, it can cause serious harm and serious damage. Thank you, Liliana, for very clear messages. We will now move on to the next question. In the context of antimicrobial resistance, to which I referred to, what about the therapeutical alternatives? How are they affected for the newborn babies in Latin America and the Caribbean? Well, there are a number of different realities. That's for sure the case. And if you can show two more images, this will be consistent with what I wanted to discuss. There are different realities in Latin America and in the Caribbean, but as we see an emergence of multiple resistant bugs, not just BLE, the old ones, but also the new strains that produce carbapenemase, the increase of methicillin-resistant Staph aureus, and many of these are the direct consequence of the prolonged use of antibiotics. There's different studies that discuss the inappropriate or extensive use of antibiotics. One of them shows that patients, premature babies, almost in half of cases, or almost in 50% of cases, had antibiotic treatments that would have been avoidable, or that they were exposed to those treatments for longer than was really required.
Not only we are going to choose this antibiotic with resistant flora, but also there are other consequences throughout the life that may occur for these patients. Today, there is a relationship, an association with allergies, increased risk of diabetes, obesity in older patients. These multi-resistant strains have an increased mortality in comparison with sensitive strains. And this is a significant piece of information. As Dr. Duran told us, neonatal sepsis, in particular late sepsis, increase death, hospital length of stay, and costs, but also patients with sepsis have a poorer neurologic development in comparison that with patients that didn't have sepsis. Thank you so much. Let's move on to the next question. What is the importance of local data for antimicrobial sensitivity, the implementation of a stewardship program to improve clinical outcomes and reduce the burden of disease. Well, of course, knowing local data will help us start the appropriate treatment as soon as possible. Also, the sensitivity data are related to prolonged use of antibiotics. For instance, when there is candida, this is an indicator of prolonged use. But we thought about this question and we made an analysis last year. Actually, we conducted a survey. We had 87 respondents. 87 institutions from 15 countries responded to this survey. And almost 50% of the respondents did not know their infection rates. Only half of the sites have a stewardship program for the rational use of antibiotics, in spite of the fact that 70% of the institutions had a pediatrician that is also an infectologist, and 30% used the sepsis calculators, which is very useful in countries with early sepsis because it's only useful for early sepsis. Something that was also strange, the low rate of the low rate of implementation of policies for hemolytic related infections. Very few sites had implemented that policies. This is one of the few early sepsis that could be prevented. But the low implementation of stewardship programs is a red flag. We must keep working to improve the figures of late sepsis and also to reduce the consequences of the prolonged use of antibiotics. Great, Liliana. Thank you so much. You've been very thorough, and I'm sure the audience has really appreciated your contribution. So we'll move on to Monica so we can continue with this conversation. Now we'll give the floor to Taina. We are going to talk about safe nutrition and feeding. Taina, when a newborn is unable to breastfeed and they require donated human breast milk, which are the key elements to ensure safe feeding through the human milk bank? Uh, Taina, your mic is on. Thank you very much for the invitation. Well, uh, I was telling Pablo how exciting these activities are. We've been trying to improve a high surveillance program in the NICU. We finally have data because without data, there cannot be action. When we saw the first data, we were really scared because the stewardship programs are essential because antimicrobial resistance is really scary. But to answer your question, Monica, the safe use of donated human milk must go from donation to administration. Every step in this process counts to make sure that the milk is safe. So we reviewed the literature, and the three most important measures are the following. Donor screening. This is very important. The first contact with the donor, questionnaire to make sure she doesn't have hepatitis, HIV, etc. And also, we must educate the donor on safe techniques to obtain and transport the milk. Also, the quality control of donated milk. Ideally, this milk should be processed in milk banks that comply with international standards on, for instance, uh, pasteurization for the right amount of time at the right temperature to make microbiologic controls before and after pasteurization. We must make sure the preservation is right with the right cold chain. In this way, we are going to prevent the transmission of diseases. Also, we need full traceability and safe administration. It's very important the identification of the donor. We need full records for storage, transportation, and thawing. It's very important to check if if it's important to make sure the right recipient for a medication, it's also to ensure who is going to be the right recipient for the donated milk. In this way, we are going to reduce the number of errors and also making it easier the follow-up of adverse events, if any. Thank you, Diana, and congratulations on the implementation of neonatal sepsis programs in Dominican Republic. Second question, when the newborn is unable to feed orally and they require parenteral nutrition, which are the three safest practices for parenteral nutrition in neonates? Well, I hope all newborns, neonates can have enteral nutrition. Unfortunately, many, in particular extreme preemies, will require parenteral nutrition. It's important to have a protocol to ensure the safety of parenteral nutrition. First, we need to ensure the standardized preparation of these foods. We need, for instance, laminar flow hoods with strict hand hygiene and hand washing, also the use of sterile scrubs, face masks. The idea is to prevent errors and contamination. Also, we need protocols for the nutrition we are going to provide according to age, to weight, to calculate the right amount of lipids and amino acids, among others. Next, we need to ensure proper administration through proper vascular access. The osmolarity is going to affect for premature neonates. We need to remove, it is advisable to remove the umbilical catheter. We recommend the peripheral lines, always complying with everything that is needed for infection control. Vascular accesses are the most frequent entry for pathogens. So this is going to be helpful to reduce the vascular access related infections. Also, ongoing monitoring. Well, sometimes we are going to have parenteral nutrition from day one. This is advisable so the child can get the proper nutrition and we can stimulate early the trophic reflexes. So maybe in the first week, we can achieve enteral nutrition to ensure proper weight, and we can remove the devices for parenteral nutrition. So it is important to follow up guidelines and standards on parenteral nutrition to reduce the complication rates. We need to measure every day electrolytes, blood sugar, among others. This is going to reduce complications related to parenteral nutrition. Thank you. And finally, the last question of this part. From a practical standpoint, which interventions, high impact, low cost interventions, would you recommend as a priority to implement in a neonatal unit to reduce nutrition associated risks? Well, the neonatology staff, nursing staffs must be aware of the impact of malnutrition in a neonatal unit. And also, we must be aware of the prolonged use of parenteral nutrition, in particular, the infections related to the parenteral devices. So, I hope that all patients could have early access to enteral nutrition, but sometimes that is not the case. Well, we all know the impact of breastfeeding. There are less infections, less enterocolitis. The earlier the stimulation of the trophic reflex, the better. Well, the mother may donate her own milk, and this does not require high technology, just educating the mother. Also, we need extraction stations so the mothers can have easy access to the extraction equipment, and these mothers will show high compliance with breastfeeding. Sometimes our mothers come from remote areas. So if we can teach them and if we can help them extract and refrigerate that milk, we will have ample availability and the clinical outcomes will be better. And these are low cost measures. We need a fridge, we need a pump, we need a private area, we need a nurse that will help the mother. And another action is daily monitoring and adjustment of feeding as needed. And we need simple tools such as daily weight. We must assess tolerance, and Dr. Quiroga is going to talk about this. Sometimes we can analyze the regurgitation. Now, this is easy to monitor within the unit. We can keep a record of this. In this way, we are going to reduce the number of days of parenteral nutrition. We are going to reduce metabolic complications. The, the stay in the NICU is going to be shorter. And of course, we are going to have less healthcare related infections. Thank you, Malena. We'll give the floor to Pablo. Thank you, Monica. Thanks to all speakers, to all the colleagues in this area. I'm sure this panel of experts with the different approaches to neonatal sepsis within the framework of a growing resistance to antimicrobials. I'm sure the audience is going to be very happy because we've answered critical questions. And also we answered many questions that were submitted through the Q&A function. Many questions will not be answered today, but they will be answered in due time through the email. So I would like to thank you. Thank you all. And Dr. Pardo, the head of the special program of AMR in the PAHO, I'm going to invite her to join us so we can ask a few questions to the experts. We are going to convey some of the questions received from you, from the audience, and we'll make the best to answer them. Thank you. I really enjoyed all presentations. I'm really happy to hear about antimicrobials, infection controls, hand hygiene. I'm really thankful for all the presentations, but we have limited time, and I want to use this little time we have left to answer some questions from the audience. So I am going to thank you in advance for your brevity. Just 1 minute per answer. Okay, thank you. First question is for you, Liliana. You have 1 minute. So the question is about antibiotics in extreme premise. So the question is how to indicate them the right way. So Liliana, you have 1 minute. Okay, thank you. Well, this is no easy question because we have very few antibiotics approved for neonates. In 2020, we had 4, and in 2022, 6 clinical trials were underway to assess the safety of these antibiotics in our patients. The younger the patients, the greater the uncertainty about the pharmacokinetics and the pharmacodynamics. Another element to assess sepsis in a very young patient. Well, this patient is sick and we have news every day. We have changes every day. They have chronic pulmonary issues, bronchopulmonary dysplasia that requires many changes. So this is a challenge for the diagnosis of sepsis, but bear in mind that acute phase reagents do not contribute to the rational use of antibiotics, nor for the indication nor the discontinuation of these. So sometimes we use antibiotics for longer than needed. And this is something said by Dr. Pablo Sanchez, a very important neonatal infectologist. He's made a great contribution on this topic. He said, allow me the doubt of sepsis with negative cultures. You may have viral sepsis, parasitic sepsis, but it's very rare to have neonatal sepsis in these patients that are immunologically compromised with negative cultures. So you must be very critical to continue antibiotics beyond 48 hours. Our patient won't be cured and the symptoms will not disappear in this extreme premise.
Thank you so much. It's so important to talk about hemocultures, but we leave this for another epidemiology webinar. That's excellent. Pablo, let me give you the floor. Thank you, Pilar. The question now goes to Ana, and also in the framework of a minute, and you did refer to the role of the nursing team. What about the main role that you could highlight exists in the role of the nurse team to prevent neonatal sepsis? Well, thank you, Pablo, for your question. Before we talk about the role of nurses, well, the rest of the speakers might agree with you that prevention, infection prevention is a team effort from the head of the department down to the last person who is responsible to choosing the unit. Nurses are the ones that do more procedures on patients. That's their responsibility. And at the same time, it grants them a role of preponderance when it comes to prevention. But the role is hand washing, maintaining sterile techniques, care of invasive devices, keeping integrity of the skin. If the skin is not whole, it's predisposing itself to infections. Nutrition plays an important role. And well, it's part of the nurse's responsibilities to give more importance to human milk. Evidence says that human fresh milk is the best indication for the newborn because of the immunological factor. Cleaning environments, cleaning the rooms, the proper use of protective gear, how to isolate patients, and how to make proper isolation. And this is where nurses play an important role when administering antibiotics, when having a culture, when taking a specimen for a culture. Well, whether it is hemoculture or any other culture, well, we should be very careful as nurses, treating the specimen carefully. And also the very important role of early detection of infection symptoms in the newborn. No one may realize about this except the family who spends all the day, the entire day with the baby. Nurses can distinguish these small details that have to do with the early detection of sepsis symptoms. Many times these symptoms are very subtle, Sometimes babies need more incubating time to regulating in order to regulate better, or maybe they don't look in an entirely normal color or reaction. Their reaction rate is not bad, but it's not normal, or it doesn't look like yesterday's reaction. And well, the role of educating family members and those that are circulating in the unit, how important how hand washing is. Without any doubt, the nursing staff are the stoppers, the ones that protect the newborn babies from being exposed to people that may not be ready to get in touch with them. But we should say that no matter how big the effort on the part of the nursing staff is, if all the rest of the members are not adequately prepared, it's a disproportionate effort. Pablo, you mentioned this, and this is one of the doorways to infections. So the role is that of hierarchy, but it's a responsibility of all across the board. And these are the points where I would emphasize in connection to what the role of nurses staff is in prevention, in infection prevention. Thank you, Anna, for an excellent answer. I will give now the floor to Pilar. Well, I'm based in Curitiba now. I'm in Brazil. We are celebrating the LATAM in Focus 2026. This is the most important mycology starting point. We are participating from PAHO in this Congress, and we're providing data on candidemias. And of the surveillance data, age distribution shows that there's lots of candidemias detected as a result of surveillance in babies younger than 1 year. Many of them will belong to this group of newborns we are discussing here about. This is a fact, and I talk about it because I think it is relevant for the discussion. And the second question has to do with the strategies that are out there in place in order to avoid infections in babies with needs of prolonged parenteral nutrition, babies that have a shorter bowel. You know that candidemia is associated to parenteral nutrition. And this question, of course, goes to Tanya, our nutrition expert. And I thank you so much for answering this question upfront. Thank you. Hello, thank you so much for this question. If we take into consideration that these children that have a short bowel syndrome will have this port of access that they will be connected to via a line to parenteral nutrition for a long time, sometimes months or years, and taking into consideration that vascular access is the main door to access or for the access of pathogens, well, of course, we need to focus on carrying the central venous catheter, continuously educating family, because these children will eventually go back home, some with nursing companionship, but in many other cases, mothers will be manipulating this device at home without the assistance of nurses. So, complying with bundles for caring or for taking care of the venous central catheter is important, very important. The careful hand washing procedure, and also when we are going to manipulate to disconnect the device, cleaning with chlorhexidine at 2% is important. It is important in these children, and in the unit, we work a lot with this, not just for those that have a short bowel syndrome, but with all. The nutrition, the parenteral nutrition line should be devoted exclusively for that. We should not use that line to also administer antibiotics or any other medication. If we used this for antibiotics, this will predispose to the growth of biofilm, therefore the growth of fungi and other pathogens. It's a central line, so these children may develop endocarditis secondary to the biofilm that is to be introduced if we were to do that. Let's avoid bacterial translocation. These children will have a very slow digestion. We should individualize the case of propinetics. This can help us push the food bolus and therefore try to avoid translocation phenomena, bacterial translocation. We should individualize in which cases it would be important to use them, especially when these children are discharged and sent back home. And we should also take from the neonatal unit, we should care and orient mothers, the use of lipids, lipidic emulsions, exposure after 24 hours can be associated to bacterial overgrowth. So these are the most important measures among these children with prolonged parenteral nutrition. Maybe Anna can contribute some more, but the most important thing here, as with anything else, are the accurate indication of hand washing and to teach how to hand wash. It's not a matter of letting mothers know that they have to wash hands or use gloves. We have to show them how the procedure is going to be done, irrespective of the fact that they will be using gloves to handle devices. Thank you so much. Excellent. Thank you. We now move on to the last question. This goes to Fernando. Fernando, how about neonatal sepsis? Is there a role to be played by the fact that the incubator doesn't have good humidity? Does it have a role to play in the detection of neonatal sepsis? It's an important factor and it is very neglected. The answer is affirmative. The incubator humidity has a direct relation with the risk of neonatal sepsis, especially among the preemie babies or extremely low weight at birth. Adequate humidity will protect babies. It helps them mature and preserve their skin. When humidity is high, 70, 85%, that will help reduce the loss of water or hydration and will keep the skin's integrity, thus avoiding the access door for bacteria through the skin. But an inadequate and prolonged management may increase the risk of neonatal infections. And by the same token, a warm, humid environment in the incubator is friendly to the proliferation of opportunistic pathogens, especially Pseudomonas, the star. So we have to be careful with contaminated water or stagnated water, or with clothes that are humid or linen that are humid. Very high humidity levels in excess of 80% for a long, long time, 14 days, 15 days will be counterproductive. So we have to be careful with the incubator humidity. We have to regulate it on the spot and use it well. Especially the nurse staff should be well trained in that to avoid, infection rates among the newborn. Thank you, Fernando, for your clear messages. And to all the subject matter experts that have participated in this block. I would like to now give the floor to Pilar for her concluding remarks. Thank you, Pablo, so much. The time has come to say goodbye. And from the Pan American Health Organization, from PAHO, we would like to thank you all for joining us in this webinar. Our most sincere appreciation goes to the presenters, panelists, moderators, and you, participants that have shared experiences and reflections on your knowledge on one of the most relevant and urgent challenges for neonatal health in our region. I'd like to thank the Latin American Infectology Association, SLIPR, the Latin American Association of Infectious Control, ATLASI. Professional associations are important partners in this area, but to all of you, panelist leaders in neonatology and infection controls that have so generously provided their knowledge. Along the webinar today, we heard a very clear message. Neonatal sepsis continues to be an important cause, an inadmissible cause of disease and death, a preventable source among the newborns. Antimicrobial resistance is being increasingly complex in preventing and in treating the disease. We heard and learned that we do have effective tools and strategies in place to face up to the challenge. Infectious control and prevention, epidemiological surveillance, microbiological surveillance, and for the next webinar. Primary early diagnosis, the clinical suspicion, as Anna was saying, and the responsible use of antimicrobials, safety in care, and adequate neonatal nutrition. From the Pan American Health Organization, we reaffirm our commitment to support Latin American countries and Caribbean countries, strengthening those skill sets. True, isn't it true, Pablo? So that through these regional initiatives for preventing and controlling infections and maternal and neonatal health, we will keep promoting policies based on evidence, technical cooperation, and exchanging experiences so that we all reduce neonatal sepsis and improve the survival and the quality of life of the newborn. The approach is integral and multidisciplinary. We need concrete actions in every hospital and in every healthcare facility, at each healthcare facility, every hand hygiene measure, every safe care practice, every therapeutical decision should be based on evidence, and every effort that you make on a daily basis contributes saving lives. The knowledge that was shared today, we hope, will inspire new actions and will strengthen the networks of collaboration that already exist and will contribute to promote efforts and accelerate efforts in our countries to secure that all the newborns have access to safe, high-quality care that is free from preventable diseases. Thank you to those that enabled this webinar, the wonderful technical team that has worked for long to culminate with this event today, and to interpreters that helped communication. You all deserve my words of appreciation. Thank you for your time and for your commitment to neonatal health and to the work that you do every day for the well-being of the newborn and their families. Have a wonderful day today. We hope we can continue to work together with this priority agenda in this region. Thank you so much. Goodbye.